Hello. I'm not sure.
Hey, how's it going? Yep, sure can.
Oh, I actually can't hear you. Give me a second.
Let's see.
I think your audio is fine. I think something's wrong with my headphones.
Hmm.
Okay, could you say something now?
Yeah, can you hear me?
Yes, you're good. Perfect.
Okay, great. Hey, and I got the background from Mary, and I tried it out. Unfortunately, I don't have a green screen, and it just ends up. Well, I can show you. It's pretty entertaining, but I end up. Or maybe I can't show you.
Yeah, do you just like disappear into the background?
Yeah, exactly.
Okay, that's fine.
Here we go. Yeah, I sort of not disappear into the background exactly, but
yep.
If our audience was taking LSD, this would be perfect. Really,
very fair.
Set things off nicely.
Yeah, don't worry about that. I can. There's an alternative thing I'll do post, so we'll be fine.
Okay, cool. And I'm just running through my slides here.
Yeah, no worries.
I will mute and hang out, and yep.
Yeah, no worries. Sounds good.
Looks good. Hi, Christian.
Hi, Mary. How are you doing?
Good. How are you?
I'm good. Hanging in there.
Interesting way we're living now, huh?
Yeah, no kidding.
I think you and I looked to Seattle and people in Washington State as our goal. If only we could be like you, because we're in the worst of it all right now.
Oh,
Yeah,
I'm sorry.
we're number 3 in death and prevalence. So,
Ouch.
yeah. So you wouldn't think Massachusetts. I was thinking we'll be fine. We have all these schools of public health and hospitals and people. All of our students went home. But yeah, we're really bad here.
Oh.
So here we are.
Yep. And we'll see what happens. I mean, it seems like, you know, we've got this first wave, and you know, still have a lot of work to get that under control. But even after that, come this fall, it seems like
Next year, the year after, it just, you know, you probably see an end in sight because you see things getting better. Do you? I mean, I would imagine if I was where you are, I'd feel like, you know, we have something to look forward to, where we're just the same, worse every day. So, yeah. I'm gonna just, we have our communication consultant. I want to make sure he gets on.
Oh, I've been on.
You are.
Yeah, sorry, I just had myself muted. I didn't realize I was talking that whole time. That's all a bit awkward, but.
Okay. All right. Well, Christian, welcome. Thank you so much for doing this. As I said, we had a great response. Over 400 people. I think we're going to reach the maximum you can get, which is 500. We had prepared a. We're recording now.
I think it automatically records, but you can pause it.
That's all right. Should we pause it? Yeah, I know, but recording now. I'm muting.
Okay, cool. Yep, me too.
So much.
All right, great. All right, thank you very much. I'd like to talk with you about organizational readiness to change in the context of implementing evidence-based practices. And I'll talk about 3 projects that I've worked on, and would like to share 3 lessons from those projects. One lesson relates to understanding the individuals at the delivery end of the evidence-based practice, the patients, and understanding the patient's experiences and how that informs our ability to implement a new practice. A second project relates to what we think are some of the factors.
Can I ask you to start? Can I ask you to start over? You know what? Can you take your headphones out? Because you won't need them, right? Do you need your headphones?
Sure. Yeah.
Because you're not going to be listening to us. And I think it's, Enola didn't have hers in. And I think it just is going to look a little more polished without it. Okay, sorry to be a jerk about this, but
no.
Okay.
No.
I got in, I was just like, I want those to be gone. It'll look better. Okay. I'm muting
totally.
again.
Yep, no worries. All right. I'd like to talk with you about organizational readiness to change in the context of implementing evidence-based practices in healthcare and public health. And what I'd like to do is talk with you about 3 projects, 3 experiences I've had that relate to 3 lessons that I've learned about factors that make us more prepared, more ready, or less prepared to implement an evidence-based practice. And the first lesson is understanding the individuals at the end of all this, the individuals who actually are on the receiving end of evidence-based practices, the patients, and the importance of understanding the patient's experiences as we are trying to deliver evidence-based healthcare or evidence-based public health. The second lesson is about thinking about the factors that we really think are driving readiness and prospectively measuring and testing those, testing our assumptions about what makes
organizations or groups of people more or less ready to implement an evidence-based practice. And then the last lesson is really about recognizing opportunity that you have not intentionally created, being ready when a crisis actually creates an opportunity for large-scale change. So the 3 implementation studies are in 3 very different settings. The first that I'll talk about is a study that is currently underway. We're just in the early stages of this study, but it's to build a shared decision-making set of tools to integrate into the process of deciding amputation level for patients with dysvascular disease and trying to incorporate evidence-based individual level prediction models into that decision-making process. The second one is a study that was conducted here in Washington State to try to promote the use of evidence-based health promotion practices in work sites. And some efforts that we made to systematically assess sites' collective readiness to implement those practices and how that influenced the implementation strategy, this program that we were delivering. And then finally, I want to talk with you about something that happened in the Veterans Administration where I work many, many years ago related to the quality of acute myocardial infarction care, cardiac or heart attack care in the VA. And something that happened that allowed us to implement a national data system in the VA. Actually, I'm going to do this slide over again. I'm sorry, I forgot that I have these bolded. So pause and so these are 3 different implementation studies in very different settings. The first is a study that's currently underway. We're actually in the early stages of this study, and it's to build a shared decision-making set of tools and process into the decision about amputation level for patients with dysvascular disease, so diabetes or peripheral artery disease, and to try to integrate evidence-based, personalized risk models into the decision about amputation level. The second is a study that was conducted here in Washington State to try to promote the use of evidence-based health promotion practices in workplaces. And I want to talk about some effort that we made to systematically assess collective readiness to implement these practices. And then the last one was an initiative many, many years ago in the Veterans Administration where I work, where a crisis occurred around the quality of heart attack care, of acute myocardial infarction care. They created an opportunity to implement a national disease registry or national quality assessment registry. And I'd like to briefly acknowledge the leads of each of these projects, Joe Sarnecki, Peggy Hannon, Steve Finn, John Rumsfeld, and the late Bob Jesse. And they represent a in each case, very large set of teams. And I'd just like to acknowledge the tremendous amount of work that each of these teams has done. Before getting into these 3 projects, I wanted to touch on the knowledge to action model. And as we were preparing this session, Dr. Slavin and the other presenters, we got together and had a conversation about what some of the commonalities were in the work that we were going to talk about. And we arrived at talking about the knowledge to action model that was developed by Ian Graham, Jacqueline Tetro, and colleagues. And I just wanted to touch on what it is and what it means. It was based on a synthesis they did of planned action theories or planned action models. And a planned action model is one in which you are deliberately trying to engineer change in a group of people, not just trying to passively let it happen. And the purpose of their model was to identify some of the common elements. And they recognized that this was a simplification, but they were trying to identify those elements or points in the process that reappear over and over again in these models. So the model begins with identification of a problem and linking it with some source of knowledge or information. It then proceeds to identify, review, select, and adapt relevant knowledge, relevant evidence to the problem. So this could be practice guidelines, research findings, some sort of innovative new program. The next step is assessing barriers to using that knowledge in a particular setting, and then selecting and implementing a set of implementation interventions to promote the use of that knowledge. So these are what we normally term implementation strategies. And then monitoring that knowledge utilization, including fidelity to use. Is it being used the way that you expected? And I'm going to pause there because I have an orange tabby at the window.
So, Dari, can you, is the quality of the sound okay?
Oh, I had myself muted. I think it's okay.
Yeah. Anything that you could suggest to get a better quality, or is this as good as it's going to get?
I feel like that might be the best.
Okay. I just want to, I always nitpick these things.
Mm-hmm.
It might be on my end, my speakers.
Okay.
Yeah. But the orange tabby, I wish this cat had come into the scene. This is the way we have to live now. I mean, I've seen it on newscasts, so
yeah, that's true.
Fine. You've seen people's dogs walking through, their kids everywhere. This is the new normal.
It really, this just drives me nuts. And yeah, and he immediately ran off, of course.
Oh. So I don't know where you want to start back with this, but.
Yep. Let's see. Let me go back.
I'm going to mute myself again.
Yep. I will start here. Okay. So actually, so here. So then we move to selecting, tailoring, and implementing implementation interventions to promote the use of the practice. That is to implement the change. It's a set of evidence-based guidelines, an evidence-based program. Oops. Oh, let me do that again. Sorry, I went backwards. Okay. So then we select, tailor, and implement the interventions to promote the use of the evidence-based practice, i.e. start implementing the change. The next step is to monitor that knowledge use, including fidelity to the evidence. Is it being used, whatever that knowledge is, evidence-based guidelines, is it being used the way that you'd expect it to be used to be effective? And if it's not, then understanding why not. The next step is evaluating outcomes, including unintended consequences, and if the implementation interventions are having the effect that you expected them to have. And then the final step is sustaining that knowledge use over time. And this is a step that in the research literature is often ignored for logical reasons. That long-term follow-up of studies is logistically very challenging. So it's something that we often know less about than the implementation process. And as you can see, this is intended to be, the circular nature of it is intended to reflect the fact that it's not linear, that things go back and forth, that we don't simply come up with an evidence-based practice, implement it, evaluate it, and then walk away, that things are constantly evolving. And also point out this knowledge creation that they put at the center of this, and what that's intended to reflect, the inverted triangle is supposed to represent a funnel. And basically the idea is that you've got this vast amount of information that's being produced, this knowledge that's being produced, whether from research or practice experience, and it represents the sort of diamonds in the rough in terms of knowledge. And this gets filtered down and synthesized, and that can include through replication, through synthesis with related findings, refutation in some cases, and then ultimately knowledge that stands the test of time gets synthesized into products and tools, guidelines, policies, decision support, things like that. So keep that model in mind as we're talking about these projects. So the first project I wanted to talk with you about is using prediction models to enhance patient and provider decision-making in dysvascular amputation. The motivation for this study was that currently clinical practice in amputations for dysvascular disease tends to focus on performing transmetatarsal amputations. So these are amputations across the foot. And again, we're talking about dysvascular amputations. These are patients who have terribly compromised circulation from diabetes, peripheral artery disease. So their circulation is really compromised, and they end up with damaged flesh that is not recovering in their limbs, and end up with the need to have an amputation. And most commonly, these start off across the foot, the transmetatarsal amputation. And this is primarily based on two things. One, patient preference. Patients generally want to minimize loss. They want to take off as much of their foot or leg as possible. But also there's an assumption on the part of the surgeons and the rehabilitation physicians that the greater the preservation of the foot or limb, the greater the function. However, there's also been good evidence for a while that there's a higher failure rate of the transmetatarsal amputation. So what that means is that the wound care is prolonged. There's a longer period of time to get them to recover from that amputation. And over that time, they have a loss of mobility. So while that wound is healing, their mobility is terribly compromised. And then what often happens is they need to actually have a repeated surgery to try to salvage that amputation. And unfortunately, in some cases, they actually subsequently have to have another amputation at the transtibial level. So they have the one amputation that fails, are back in the hospital for another amputation. And all of this is occurring in the context of a group of patients for whom life expectancy may not be very good. And so we have this horrible situation where patients with not great life expectancy could spend a significant portion of the last years of their lives undergoing amputations, recovering from amputations, trying to rehabilitate, only to have another surgery, another amputation. So my colleagues, Joe Sarnecki and colleagues, made this observation that for some patients, you could achieve better functional life years, return them to a higher level of mobility more quickly for a higher quality of life, possibly by just doing a transtibial amputation, a more aggressive amputation initially. So what do you need to do that? You really need personalized risk models. You need some way of telling which patients are at the highest risk of needing reamputation, which patients are most likely to return to mobility with a transtibial amputation, and of course in the context of what their life expectancy is. And so Joe and colleagues, including Dan Norvell, they've developed a series of these patient-specific, so personalized risk models or probability models for mobility, reamputation, and mortality. So they've developed these models, and now the current study is to try to understand how those can be incorporated into practice to help patients and providers make decisions that are aligned with the patient's goals. So it's not to tell the patient that they should have a transtibial amputation. It's to give them all of the information and to give their surgeons and rehabilitation providers the information to make the best decision that aligns with the patient's goals. And the question, of course, is just exactly how to do that, when and how to introduce that information. And Joe, to his credit, started off this study very fundamentally trying to understand the patient experience. So the first aim of this study was just to do a series of interviews with veterans who had had an amputation recently to understand their lived experience and how did the patients experience that decision of the amputation level. And to understand what went into that decision and what was important to them in that decision. And for that to then provide context in which to develop decision aids or decision tools and some sort of shared decision-making process for the patient and the provider. So these are in-depth interviews. Our colleagues, the qualitative interviews, summarized each interview and discussed in weekly meetings. We had 2 researchers do this. They tried to surface their own biases in these discussions. They discussed the relationships among the interviews. And this initial set of findings are just a key set of elements. These are emergent findings. These were not things that we went into looking for, just what emerged inductively from the interviews. And I should say these are highly preliminary, but very, very interesting. So this was just an initial set of 12 interviews, again, a preliminary analysis of this lived experience of having an amputation. And I'll just point out a couple of things. One, in terms of the amputation level, we had 3 patients who had a transtibial amputation. So a quarter of them had transtibial. 4 of them had a transmetatarsal amputation with no revision. So the amputation, transmetatarsal amputation went fine. And then a transmetatarsal with some revision. 5 of them had some revision. 6 of these amputation decisions occurred in a clinical setting and an appointment. 6 of them happened in the emergency department. And then geographically, we had good representation. There were 5 preliminary findings about aspects of the experience of making this decision. I want to talk about this first one, the passive participation in the amputation process, because it will influence the way we approach creating decision support tools and trying to understand where to incorporate this information into the process. And it's really about the patient's perception that the necessity of the amputation arrived and they did not perceive an opportunity to make a choice. They said things like, it had to be done, I had gangrene, what choice did they have? Or they decided that they needed to amputate. And that's captured really well in this quote from a veteran who said, no, he, meaning the provider, just told me that it's a procedure that has to be done. He said he wished he couldn't do it, but that it had to be done. That was just the bottom line. Other than that, like I said, he just gave me confidence in the nurses too that were there. So I just went on and did what I had to do. Most veterans couldn't describe specific details of their conversations with providers or surgeons prior to the amputation. And some described the amputations that took place while they were anesthetized. Oh, I can't even say it. Damn, I'm gonna start this one over. Anesthetized. I'm sorry, just a sec. All right, I'm going to go on to the slide. Most couldn't describe specific details of their conversation with the doctor or surgeon prior to the amputation, and some described amputations that took place while they were anesthetized. No, Jesus. I'm just going to say medicated. Okay. Most couldn't describe the specific details of the conversations with the doctor or surgeon prior to the amputation, and some described the amputations that took place while they were medicated with little or no prior conversation. One veteran described frustration due to lack of choice. A few did perceive a choice in the degree of amputation. One participant described the choice to amputate his entire foot rather than his toes in order to avoid a future lower leg amputation. Another told his surgeon that he was unwilling to lose his entire foot. And another couple of exemplar quotes. There wasn't really much conversation about my foot coming off. It didn't feel very good. I mean, not having a choice. So again, overall, we see this experience of veterans encountering this really life-altering choice and feeling like they had little say, and in fact, not even being really aware that there was a choice to be made. There's some serious implications for when and how we introduce the idea of these patient-tailored risk models and decision aids into the amputation process. First, we may need to find ways to introduce the idea that there are options sometime earlier in the care, and particularly, obviously, for the patients who end up in the emergency department making this in an acute situation. We might be able to look for earlier points in the care pathway to start the conversation. And clearly, there needs to be some kind of space created to have that discussion, some sort of opportunity for a dialogue between the patient and provider. But that's going to have to happen sometime before, again, they're in an acute situation. The next project I'd like to talk about is this project here in Washington State implementing evidence-based health promotion. I'm going to start over, sorry. The next project I'd like to talk about is implementing evidence-based health promotion practices in low-wage work sites in Washington State. So evidence-based health promotion interventions, I'm just going to call them evidence-based interventions, decrease risk for chronic diseases via health behavior. So increasing physical activity, improving eating habits, and smoking cessation, for example, or tobacco cessation. These are all linked to improve the health outcomes. The issue becomes where to deliver these evidence-based interventions. We know that health behaviors are very difficult to change. A promising setting for altering health behaviors has been the workplace. Over 60% of people 16 years or older are employed, and there have been a number of interventions at work sites that make them a promising venue for delivering evidence-based interventions. However, small and low-wage work sites tend to have limited access to evidence-based interventions. We have good evidence that they do, and have barriers to implementing evidence-based interventions. Compared with larger companies, these smaller work sites are less likely to offer evidence-based interventions, for example, to support cancer screening, healthy eating options, to promote physical activity, or again, providing tobacco cessation support. And in particular, small work sites in low-wage industries. So we know small work sites compared to larger work sites are less likely to offer evidence-based practices. Small work sites in low-wage industries are yet, again, less likely to offer evidence-based interventions. And these are precisely the work sites that are most likely to have employees with low socioeconomic status who are at the highest risk for chronic diseases. So the individuals at highest risk are working in the workplaces that are the most challenging to deliver these evidence-based health promotion practices. Some of the barriers that we know of in these settings are lack of time. This is no surprise, I think, to anyone. Lack of time, accessibility in terms of having access to these evidence-based interventions, and then resources to implement them. A literature review of worksite health promotion interventions for low-wage work sites identified interventions that targeted both individual and organizational level practices. But most of the focus so far has been on individual level outcomes, trying to change the individual employees. And my colleague Peggy Hannon and the team at the University of Washington Health Promotion Research Center were interested in developing a program to engage small, low-wage work sites in implementing and maintaining evidence-based interventions over time, and in particular, understanding some of the organizational factors in implementing these evidence-based interventions. So Peggy Hannon and colleagues led this trial in collaboration. This was a NIH, sorry, I'm going to start over again. So Dr. Hanning and colleagues, oops, oh, good Lord. So Dr. Hannon and colleagues at the University of Washington Health Promotion Research Center developed this trial sponsored by the National Cancer Institute to conduct a 3-arm trial over 2 years to implement a package of evidence-based health promotion practices in low-wage work sites in Washington State, in King County in Washington State. And the implementation strategy was this program called HealthLinks. And HealthLinks was led by a trained interventionist, health promotion practitioner, public health practitioner. And the idea was to lead it in 4 stages, to have an initial baseline assessment of current practices, again, around cancer screening, healthy eating, physical activity, tobacco cessation, come up with recommendations for which evidence-based interventions to implement based on responses, the employer's responses to these assessments. And then to implement those evidence-based practices and then follow up over a period of months to try to maintain those evidence-based practices. And that initial phase was just over a couple of months, that initial assessment and tailoring of the evidence-based practices. And then there was this follow-up period up to over a year later. And that follow-up period focused on 3 to 5 evidence-based practices selected by the employer, and again, with the idea of tailoring these evidence-based practices to their needs. And one of the things that we did as a part of this was did a systematic assessment of organizational readiness to change. And this was based largely on Brian Weiner's theory of organizational readiness. And the idea is that readiness comprises 2 shared affective states. So it's the way that employees in a given setting feel about a practice change that's to be made. And the first component of readiness is change commitment. Basically, change commitment refers to how the employees or the organizational members, how they feel in terms of shared resolve to pursue the courses of action that will lead to implementation of the practice. The other is change efficacy, and that really refers to organizational members' shared beliefs in their collective capabilities to organize and execute in a way that leads to effective implementation of that evidence-based practice. So shared commitment to it, to achieving that outcome, and shared efficacy, we can collectively do that, do this. And the idea that those 2 things approximately are what result in effort, the actual actions being taken to implement the practice. And then those efforts are what goes into implementing the evidence-based practice. And so as part of the HealthLinks program, we assessed organizational readiness to change in terms of change commitment and change efficacy. And our supposition was that this readiness to change could have two influences on our outcomes, on the implementation of these evidence-based health promotion interventions. One is that we could see essentially a direct effort. So readiness to change at baseline could be a key determinant of implementation efforts. So irrespective of what arm the work sites got randomized to, maybe their baseline readiness was going to be an important predictor of their implementation effort and subsequently their implementation of these evidence-based health promotion interventions. We also thought that there could be an interaction effect, that the sites that were randomized to the HealthLinks intervention, there were 2 arms I'll talk about in a second, but the sites that were randomized to the HealthLinks arms, if they exhibited a high level of baseline readiness, a high level of commitment to this change, and a high level of collective self-efficacy about the change, that they might do better than sites randomized to the HealthLinks arm that had a relatively lower level. So we might see this interaction or modifying effect or moderating effect of HealthLinks on implementation effort and subsequently on the evidence-based practice. We wanted to know, are baseline change commitment and efficacy independent predictors of implementation effort, across all of our study arms, these 3 study arms, and or our baseline change commitment and efficacy effect modifiers of the effectiveness of the HealthLinks program. Let me go back and do that since I just wiped my nose. Actually, speaking of which. So we wanted to know, are baseline change commitment and efficacy independent predictors of implementation effort, i.e. independent predictors of worksites' effort to implement these evidence-based health promotion practices, and or are baseline change commitment and efficacy effect modifiers of the effectiveness of HealthLinks? So are these baseline conditions interacting with whether or not sites were randomized to HealthLinks? Actually, and I'm going to pause there. I thought that I went over HealthLinks. You know, I just realized I'm going to do this slide over again because let me just make sure that I don't lose my place. Yeah, okay, so I'm going to pick up back here at methods in just a second. But I want to do this again because I failed to mention the 2 arms, and I apologize because I thought this was in here. Okay, let me see. So in HealthLinks, a trained interventionist, health promotion practitioner, engaged with each of the sites in 4 phases. The first phase was to assess the employer's current or baseline implementation of these health promotion practices, these evidence-based interventions. So this included cancer screening, for example, colon and breast cancer, healthy eating options, making sure if there was food provided in the work site that there were healthy options, providing physical activity or encouraging physical activity, for example, arranging for discounts at a local fitness center, and tobacco cessation interventions, for example, offering the Washington State Quit Line information available at the work site. So the interventionist worked with the site to identify the evidence-based interventions to implement based on responses to this assessment. And that occurred, that phase 1 and 2, that occurred over the first approximately 2 months, and that was through in-person contacts between the trained interventionist and the work site. And then for phases 3 and 4, phase 3 was the implementation of the evidence-based interventions, and this occurred over a period of over a year. And then phase 4 was a maintenance period, was a follow-up period just to track, and this occurred over the final total period of 24 months to see if those evidence-based interventions remained. And we had 2 arms in the HealthLinks intervention. There was HealthLinks by the trained interventionist, again with these in-person visits. That was the HealthLinks arm. In addition to HealthLinks, we had an arm where we required sites, if they were randomized to that arm, to form a wellness committee. So to actually have employees at the site form a wellness committee that was then responsible for implementing these evidence-based practices. And our supposition was that the formation of that wellness committee might create a structure, an organizational structure that would increase the collective responsibility for implementing those practices. Now, as a part of this study, we systematically assessed organizational readiness to change. All right, I'm going to skip back ahead to methods. So to assess this, we completed surveys at baseline, 15 months, and 24 months. And these surveys were completed by the site champion. This generally was the HR, human resources manager. And then we conducted a multivariable regression analysis where the outcome was implementation effort. And implementation effort was 5 questions related to implementing the wellness program. This included, for example, having Readiness wellness goals. So these wellness goals that were targeted by these evidence-based interventions, having a budget for health promotion and wellness, in the amount of time that the champion reported that they were able to spend on wellness program implementation and maintenance. So that was the outcome, this effort. And then our independent variables were the organizational readiness to change factor, change commitment, and collective efficacy. And then we adjusted for trial arm, company size, in the industry they were in, like for example, service industry or manufacturing. We also looked at the aggregate evidence-based intervention score. What percentage of those evidence-based interventions that they set out to implement did they actually implement? So that was ranged from 0 to 100%. And I'm going to scratch my nose again and then go on. So we had 69 of the 78 sites complete all 3 assessments. Change efficacy exhibited poor reliability, which was really an unreliable measure of the items did not correlate well with each other. So responses about one aspect of efficacy didn't correlate with another. We ended up excluding that. What we saw was that the effort, again, so that's things like amount of time that the champion said they could spend on health promotion or having written wellness goals. Wellness program increased over time in both intervention arms, both the health links, just with the interventionist reaching out, and the health links plus the wellness committee. So where they had the interventionist, but they also formed their own wellness committee on the site to be responsible for the interventions. And we saw that the arm with the wellness committee, so the health links plus the wellness committee, at 24 months, they had sustained that increase in their wellness program effort. Change commitment was psychometrically stable, but when we tested it, it was baseline change commitment was not associated with wellness program effort at either 15 months or 12 months for any of the arms. And we tested not only wellness program effort from baseline to follow-up, we also tested total wellness program effort, so relative change and then absolute change from baseline to follow-up. And then we also looked at wellness program implementation. So not just our proximal outcome was, were they taking the steps, again, written wellness program goals, having a budget for wellness program. That was our proximal outcome, but we also then looked at implementation. Did they have healthy eating options? Did they have interventions implemented to promote physical activity? Did they offer information about cancer screening? We looked at all those outcomes and we found no association between change commitment, so commitment to implementing evidence-based health promotion practices. We saw no change, no correlation between that and change in effort or outcomes. We also tested change commitment again as an effect modifier. So among those who had high commitment at baseline and who happened to be randomized to one of the health links arm, was there some sort of added benefit? Were the high commitment sites that got randomly assigned to health links more likely to implement these practices or more likely to exhibit effort than the sites that had low commitment? And we found, again, no association. There was no effect from baseline change commitment. We also looked at other measures of organizational context, favorability of the context to implementing quality improvement at the work site. And again, we found no association. And I just want to stress that evidence-based implementation, the outcome was positive for this trial. So both of the intervention arms, health links and health links plus the wellness committee, had higher implementation of these evidence-based health promotion practices at both 15 months and 24 months. There was some backsliding at 24 months, but it was still significantly higher. And this was bolstered by reports from the employees. We also did survey work with the employees, asking them how much they perceived that there was support in their workplace for their wellness and for their health. And employees that were at work sites assigned to the intervention arms perceived greater support for their health at both 15 and 24 months. So the intervention was effective, but we still found no effect from this baseline factor of change commitment that we thought was going to be an important determinant of their ability to make this change. So what are some of the, actually I'm going to, sorry, back up again to this. This really is talking about what I had just said. So again, we failed to find that baseline change commitment was either an independent predictor of implementation of evidence-based health promotion practices or an effect modifier of the implementation strategy. And importantly, the implementation strategy was effective, i.e., this was not simply a problem of a lack of change in the implementation effort or the actual implementation of the evidence-based practice. And I'll just note that we previously had done an analysis just looking at change commitment over time and what happens. And what we actually found was that change commitment declined over time, even as implementation effort was increasing. And what we concluded was that likely this was regression to the mean, that when sites signed up, they were probably randomly a little bit, they were randomly higher in their level of commitment or level of interest in health promotion. And they would sign up for the study. And then when we would assess change commitment again later, they would have regressed to their natural mean. Nevertheless, the important thing that we think here is, at least in this setting, and this is just one setting, this is just one intervention, this was just one point in time. Actually, again, I apologize, I'm going to do this. I'm going to do this over again. So again, we failed to find that baseline change commitment either independently predicted implementation of the evidence-based health promotion practices, nor did we find that it was an effect modifier of the implementation strategy of the HealthLinks program. And the important thing here to remember is, again, the implementation strategy, the HealthLinks program, both the regular HealthLinks with the interventionist doing the in-person support, and HealthLinks plus the formation of a wellness committee at the worksite, both of those were effective. So this was not a problem of the implementation strategy simply being ineffective. It's also important to note that we previously found that change commitment declined over time. So we also looked at change commitment over time among these worksites, and we found that across all three arms, change commitment declined significantly, but modestly, in all three arms over time. So it declined from baseline to 15 months and from 15 months to 24 months. The important thing here is we think that most likely this represents regression to the mean. Our supposition is that sites, when they signed up for the trial, were probably randomly a bit higher in interest in health promotion, and therefore they signed up. And that over time, they regressed in their interest and commitment to what was their more natural mean. So we don't think that this is a true decline in change commitment over time. For example, some sort of exhaustion from implementation efforts. Nevertheless, we think that the important thing is, at least in this instance, this practice, this one setting, we saw sites increase their implementation effort and have that implementation effort translate into effective implementation outcomes that were perceived by employees in the absence of change commitment, any sort of detectable effect of collective change commitment. This is important as we think about other studies, both of organizational readiness to change and factors such as climate for quality improvement or climate for implementation. Much of the work that's currently done in the field is done cross-sectionally using surveys that ask both about some outcomes, some level of implementation of a practice, and affective states such as commitment, efficacy, motivation, for example. And we think that our findings underscore the importance of prospectively assessing and testing these types of constructs and understanding if they in fact correlate with the outcomes, predict the outcomes we think they will. We also think that it may be more useful in some situations, some settings, to assess more structural factors. We think that it was highly relevant that measures of implementation effort, again, time spent on evidence-based health promotion interventions, having wellness program budgeted for, these structural factors were correlated with implementation of the evidence-based practices. The third project that I'd like to talk with you about is when crisis becomes an opportunity. And this is from an experience many, many years ago that I was involved in when the VA commissioned an external audit as part of the Government Performance Results Act, or GPRA. This was enacted in 1993 by then Vice President Al Gore to have some government accountability through external audits of key processes. And the VA had this audit of their acute MI quality of care. And it was conducted by Harvard and PricewaterhouseCoopers, and the report was delivered in March of 2003. The analysis was based on administrative data from the mid-90s, and they were looking at a number of quality metrics, including 30-day mortality from acute myocardial infarction or heart attack, annual mortality, and also some quality of care metrics around medications at admission and discharge, and access to procedures to coronary artery bypass grafting and percutaneous coronary interventions. Sorry about that, and I'm going to do that one over again as well. And let me do this. Okay, do this one over again. So this was an experience I had many, many years ago. I'm going to do that over again. So this was from many, many years ago when the VA commissioned an external audit as part of the Government Performance Results Act, or GPRA, of 1993. The VA was required to have an audit of some internal process to try to improve the performance of the services they provided. And the VA selected acute myocardial infarction or heart attacks. This external audit was performed by Harvard and PricewaterhouseCoopers. The report was produced in March of 2003, but it used data from the mid-90s, and it assessed both heart outcomes, 30-day mortality and annual mortality from acute MI, as well as some quality of care metrics, including provision of coronary artery bypass grafts and percutaneous coronary intervention. So these are the procedures to return perfusion to the coronary muscle to unclog the coronary arteries that are blocked and causing the heart attack. And what this report concluded was that 30-day mortality, after taking into account patient age and other risk factors, the 30-day mortality was 3.5% higher in the VA than it was in a similar population of Medicare patients, and then annual mortality was 6.5% higher. And again, the quality metrics, the use of these coronary interventions that would restore blood flow to the heart, that these were used significantly less often in the VA than in the similar patient population of Medicare patients. And this gap seemed to persist. So there's a later paper in the late 90s, from data from the late 90s, didn't seem to be much better. And of course, this hit the press. This is a little snippet from the Washington Post. But the key things are they're reporting that VA hospitals have consistently higher mortality rates than patients of similar age and roughly similar health who are treated at non-VA institutions. And the lower paragraph here, and they have only about half the likelihood of undergoing angioplasty or bypass surgery, two procedures that can often extend life. So it was a pretty damning report. It looked like the VA was skimping on these procedures that can often extend life, and that the result was higher mortality for veterans. So at the time, there was some skepticism about the the validity of those findings within the VA, because there had been prior data showing that the quality of AMI care in the VA was generally fairly good. And in point of fact, this was many years later, but many years later, there were subsequent analyses that found that the external audit erroneously compared Medicare patients who were admitted for an AMI to veterans who both were admitted for an AMI and veterans who had been admitted to the hospital for something else and then had an AMI while they were in the hospital. So it was not an apples to apples comparison. And as it turns out, patients who were admitted to the hospital for something else, for example, a surgery, and then have a heart attack while they're hospitalized, have much, much higher mortality than other patients. And again, this was many years later, but subsequently, researchers found that, in fact, the difference in mortality was not there, that it disappeared once you actually adequately adjusted for those differences and made it an apples-to-apples comparison. However, at the time, that wasn't known. And the VA, to its credit, instead of ducking and covering, undertook a large-scale change to try to improve the quality of AMI care. And there were a number of actions taken. So they, first of all, named a national chief consultant for cardiology, national program manager for cardiology to have overall control. They formed a steering committee to advise the national chief consultant. They made each of the regional Veterans Integrated Service Networks, and these are regional organizations of VA medical centers, made each network develop an action plan for improving acute MI care. They developed new performance metrics. There was a series of national training conferences to try to share best practices around heart attack care. There was investment in new equipment and new cardiac cath labs to make the coronary interventions more widely available. There was some updating of guidelines to make sure they were concordant with the current American Heart College of Cardiology guidelines. And then there was a technical assistance program, basically to codify some of the best practices being surfaced at different VA facilities. And all of this was evaluated through this multifaceted, multi-method evaluation, national evaluation program. And there was another action that was taken, and that was the formation of a national data registering quality tracking system, a software package. And the purpose of this software package, the data that was available on acute MI and on patients receiving coronary interventions, because at the time that the audit occurred, the VA didn't even have a way of determining how many coronary interventions were being provided or what the outcomes were. And so one of the results of this initiative was the formation of this program, the Clinical Assessment Reporting Tracking Cath Lab System, or CART-CL system. And CART-CL was essentially a homegrown system developed by research with clinical operations leaders in the VA. And it was a module that was designed to interact with the electronic health record. And one of the important things was that it linked with the existing VA electronic health record, and it would draw out data elements, pre-populate data elements in CART from the electronic health record, so avoid duplicating data entry and avoid data errors by trying to from the electronic health record manually into CART. And then it produced consistent formatted reports that then could be exported back into the electronic health record. And it would do this so efficiently that often by the interventional cardiologist as the patient was still on the table in the post-procedure monitoring period. But CART would produce these structured data elements common across all VA cath labs, allowing for the first time really national tracking of quality metrics, case volumes, and really a prospective real-time assessment of coronary intervention. And there were several things that happened as a result of this, just two that I'll mention. One, it allowed VA to put into place a real-time alert system. So within 24 hours of any adverse event in the cath lab, an unexpected death, for example, there was an automatic alert system. There is now an automatic alert system, so that National Program Director for Cardiology and this advisory board, this field advisory committee, are alerted when there's an adverse event in the cath lab. Another thing that it facilitated is, for the first time, as far as I know, anywhere in the country, there is a post-marketing monitoring program through CART for cardiac devices. So cardiac devices, after they've been approved by the FDA, sometimes it's only once they get out into the field that there are sufficient numbers of cases for problems related to that technology to emerge. And CART is such a big database, and it has these structured fields where the CART system keeps track of the devices being used, making it possible to do this post-marketing surveillance to determine if a device, after it gets on the market, actually has problems that only emerge when a sufficient number of patients have been exposed to it. So these are these important quality improvement byproducts of having this system put into place. And now, over time, CART has actually evolved, not just, it's now not only a database, but it's actually evolved into an operational program. It now includes, let me start that over. And CART is no longer just a cath lab registry. It has now evolved into an overall operational program. It includes quality programs to improve point of care analytics. It improves safety programs to review adverse events, as I just mentioned. And it provides reporting to facilities, making it transparent about operators' performances in cardiac procedures. So operators can see their performance. Actually, I'm going to start that over again. I apologize. And CART is no longer just a cath lab registry. It has evolved into an overall operational program. It includes quality programs to improve point of care analytics, safety programs, as I mentioned, that review adverse events essentially in real time, and reporting programs that try to provide some transparency to facilities and to operators on their performance relative to the system. And this work has been associated with improvements in clinical outcomes. Even over this period, even as patient complexity, so the complexity of the patient has increased over this time, meaning we would think it would be getting worse outcomes, but quality outcomes have actually improved over that time. So what's the lesson here? Well, this could have turned out actually quite differently. The reason I believe that CART was developed the way it was because the organizational context when this crisis happened favored a coherent response that involved quality improvement experts and researchers. Before this crisis hit, before the external audit, VA had established a formal embedded research and quality improvement program, the Quality Improvement Research Initiative. And this is a collaboration between health services researchers and clinician leaders. And originally it was focused on high impact clinical areas, for example, severe mental health, diabetes, and ischemic heart disease. The cardiologist who ended up being tapped to lead the national response, to be that first National Chief Consultant for Cardiology, Dr. Bob Jesse, he served on the Strategic Advisory Committee for the ischemic heart disease. So he was familiar with the program and had a working relationship with them. And he'd already been and had already had conversations with the leaders of the ischemic heart disease query, Steve Finn and John Rumsfeld. He'd already had conversations about the need to have some sort of data tracking system for the quality of ischemic heart disease care. And he articulated a set of principles that he wanted to see in a data system for acute MI. And I should say more generally, he articulated a set of principles for clinical data systems. One of these principles was that data needed to be collected at the point of care. He said, if it's not important enough to collect at the point of care, then it's probably not important enough to be collected. And if it is really critical to have, then it's important enough to take the care to collect it at the time of the clinical encounter. He wanted to have the data immediately available. His mantra was having system-wide transparency, so have those data available to let everyone see what's going on in the system. And that these data are collected through data collection tools that make the flow of care easier, not harder. And that was one of the keys with CART, was making that data system, that data capture happen in the cath lab during the procedure. Again, the CART reports are often completed even as the patient is still on the table because it's done there during the procedure. And the tool makes it very easy to do that data capture. So these are some of the principles that he articulated. He then collaborated with researchers and quality improvement scientists in the VA to develop the system. And at first it was a competitive process. I think the important thing is this work on CART was emblematic of how an embedded research system can help foster the qualities of a learning healthcare system. That the embedded researchers were there at the outset. The clinical leaders involved this program at the outset. So then when a crisis happened, if you were to go out and try to form relationships with researchers and data scientists in the midst of a crisis, it would just be very, very difficult to do. So this was something where the health systems leaders had already involved the researchers and data scientists at the outset, so they were in at the ground level. The healthcare leaders articulated a set of clear goals, a set of clear principles. They didn't say how to do it, but they articulated these principles of what the product needed to do. And then the funding was aligned with the work. The Quality Enhancement Research Initiative is a collaboration between health services researchers, the research arm of VA, and clinical operations, but it's actually funded by clinical operations. So the money that was going into this program was funded by the healthcare dollars, and they needed a rapid turnaround. They needed something very pragmatic, and so that funding was aligned with the work. And of course, there's this quote that I think we've all seen, and that I think speaks to many of us, that chance favors the prepared mind. And I think there's an analogy at the organizational level that crisis favors the prepared organization. So if we have these structures in place, when a crisis happens, we can't predict when a crisis happens, but when it happens, if we have the structures in place, we can respond to it. And a crisis represents opportunity because it unfreezes things and it focuses people. So even individuals in the same organization often have many competing demands, many competing responsibilities. And a crisis tends to focus everyone on the same or a similar set of goals. And for that reason, it represents an opportunity, but only if you have the structures in place to take advantage of it. So those are 3 implementation projects and 3 lessons that I wanted to share with you. So again, this understanding the patient experience of the evidence-based, of the clinical context in which we're trying to implement this evidence-based practice, so essential for us as we move forward with implementing the practice. The importance of us prospectively assessing and testing the organizational factors that we think drive implementation, rigorously testing these conceptual models we develop is really essential. And then again, putting structures into place that allow us as researchers and quality improvement scientists and quality improvement clinician leaders, putting these structures in place that allow us to take advantage when the unexpected happens, when a crisis emerges and shakes things up and creates an opportunity to create change. And I'd just like to, before closing, would just like to return to the knowledge to action model. And one of the things that I think was really prescient of Ian Graham and Jacqueline Tetro and colleagues was that they recognized that the knowledge translation cycle did not just involve implementing new evidence-based care, but that process of continuously generating knowledge and continuously evaluating knowledge also included abandoning ineffective knowledge, recognizing when there were practices in place that either no longer were true, something that at one time was a best practice has been superseded, or was actually never true, that we misunderstood. And of course, the classic example is antibiotics for upper respiratory infections that continue to this day to be a problem. So they recognized that this knowledge generation process also involved knowledge exploration and recognizing when that happens. And the other thing that they recognized was that the volume of knowledge created actually becomes its own challenge, can become its own problem. The example that they cited was this research on cirrhosis and hepatitis, where over a period of half a decade, only 60% of the conclusions originally produced, this was 1945, but only 60% of the conclusions were still valid, 19% were considered obsolete, and 21%, over 1/5, were considered outright false. And this is something we actually see across clinical disciplines. Knowledge expires over time. So that's what I would just leave you with, that this process of knowledge translation is iterative, and it involves both evaluating new promising practices and integrating them into current practice, and also reevaluating our existing knowledge base and knowledge practices and omitting those that have become obsolete. Thanks so much for having me, and I look forward to the discussions that are going to follow.
Okay, sweet. I stopped my recording, so you should be good.
Okay. Yeah, I don't know if there were any total duds in there. Anything that
I stopped my recording.
Okay.
Yeah.